Hello, everybody. This is Dr. Cole, and today we're going to show a case where an arthroscopic HAGL repair was performed along with a posterior labral repair and an arthroscopic-assisted AC joint reconstruction. This is performed by Dr. Chirag, Sheth, and Dr. Wendell Cole out of Resurgens Orthopedics in Atlanta, Georgia. The case is a 29-year-old male who sustained a closed injury to the left shoulder after being involved in a motorcycle accident. There was no loss of consciousness. He felt as if his shoulder popped out of place, but there was no formal reduction required in the emergency department. He has no significant past medical history or past surgical history. On physical examination, he has a gross deformity about the AC joint without any skin tinting or compromise. He has diffuse tenderness and palpation about the shoulder. He had minimal active range of motion secondary to pain and pain with passive range of motion about the shoulder. However, distally, he was nervascally intact. Multiple x-ray images of the left shoulder shows a displaced AC joint separation with greater than 100% of displacement. There is no obvious bony abnormalities to the glenohumeral joint, and the glenohumeral joint is reduced. MRI findings: on the left, a coronal T2 weighted image shows a HAGL lesion that you can kind of see on the right side as well. And you can see signs of the AC joint separation with the edema on the superior aspect of the image. On this T2 weighted axial cut, there is a tear of the posterior labrum that is identified. Regarding decision-making, on the humeral avulsion of the glenohumeral ligament, this can be treated non-operatively as well as operatively. And operative treatment options, there are a multitude of open versus arthroscopic repair techniques. For the posterior labrum, this can also be treated non-operative or operatively with posterior labral repair. And for the AC joint separation with the amount of displacement, sometimes this can also be treated non-operatively, or there are a multitude of different operative techniques that can be utilized to treat this patient, or arthroscopic techniques as well. So our plan for this patient was to undergo arthroscopic-assisted AC joint reconstruction with an allograft, posterior labral repair, arthroscopic, as well as an arthroscopic repair of the humeral avulsion of the glenohumeral ligaments. The patient was placed into the B-chair position. This is diagnostic arthroscopy, which shows a HAGL lesion, where here you can clearly see the injury to the capsule. And also, you can see the injury to the posterior labrum. So at this time, a standard anterior portal as well as a posterior inferior portal was established. And here we're using a suture passing device, a curved device, to pass the nitinol wire through the capsule, and this is eventually going to be placed into a knotless anchor after the insertion site is repaired on the humerus. And here you can see reduction of some of the capsule back to its origin on the humeral head. And again, another anchor is going to be placed. So here another pass is being taken through the capsule, and the nitinol wire is placed. That way there's enough nitinol wire in the joint. And then this is going to be fed into a knotless anchor, which can be seen here going into the humeral head. And you can see the reduction of the lesion. And now this completes the HAGL repair. Next, we turned our attention to the posterior labrum. So the labrum is lightly debrided, and it is elevated using an elevator from the anterior portal. And using the posterior portal, the bony surfaces is prepared. And in standard fashion, sutures bites are placed through the labrum. And these are all fed into knotless anchors. So multiple fixation points was utilized for the posterior labrum. And this is the final construct here. So attention was then turned to the AC joint reconstruction, and an anterior portal was established more laterally, and the interval tissue was debrided, and the undersurface of the coracoid was also cleared off. And here the guide is being placed, and you really want this to be more posterior on the coracoid. If it's a little too anterior, that could lead you for a fracture. So a nitinol wire is passed, and then a passing suture is passed in order to pass the eventual dog bone, which is going to be placed here. A tip is to guide the dog bone in using a grasper. And then the decision was made to augment this with an allograft. So a switching stick as well as an obturator and a fiber stick or some type of passing device is placed posterior to the clavicle and medial to the coracoid, and another one is placed lateral to the coracoid and anterior to the clavicle. And here the graft is being shuttled underneath the coracoid here, and it is going to end up being tied on top once the joint is reduced using fluoroscopic guidance. And then the two limbs are brought over to help reconstruct the AC joint, which can be seen here. Here are our postoperative films showing dog bone in place with suspensory fixation with the reduced AC joint. Postoperatively, the patient is allowed to begin passive range of motion on postoperative day 1. They're in a sling for a total of 6 weeks. At week 6, active range of motion plus active assisted range of motion is started, and strengthening is began at weeks 8 through 10.